So next is respiratory failure, and define respiratory failure. An arterial partial pressure of oxygen at rest less than 8 kilopascal. It's classified into two types depending on the level of partial pressure of carbon dioxide. So type 1, hypoxemic respiratory failure, results from the diseases that damage the lung tissue, and it's due to the right and left shunts or ventilation perfusion mismatch. The partial pressure of oxygen can be normal or low due to hyperventilation as a response to hypoxemia caused by chest infection, PE, pulmonary edema, asthma, ARDS, and aspiration pneumonia. Type 2, hypercapnic respiratory failure or ventilatory failure. Hypoxemia with arterial partial pressure of carbon dioxide exceeding 6.5 kilopascals. Less carbon dioxide is excreted than the produced due to the alveolar hypoventilation. Results from the reduced central drive like opioids, anesthetic agents, intracranial pathology, sleep apnea. Impairment of peripheral respiratory system, for example, airway obstruction, COPD, exacerbation restriction due to pain, obesity, ascites, and myopathy. May also occur if a patient with type 1 failure becomes exhausted and unable to maintain compensatory hyperventilation, a sign of impending respiratory arrest. How do we monitor respiratory function? So respiratory rate, oxygen saturation, inspired oxygen to maintain the target saturation, conscious level, end-tidal carbon dioxide, and blood gas analysis. What are the signs of respiratory distress? So it's tachypneic, inability to sleep, mouth opening during inspiration, pursed lips, expiratory grunting sounds or groaning, use of accessory muscles, cyanosis, tachycardia, dilated pupils, sweating, restlessness and fidgeting, and then anxiety, apathy, and eventually coma. Then what are the risk factors for post-operative respiratory failure? So patient risk factors already respiratory disease, smoking, obesity, immunosuppression, surgical factors, emergency surgery, and upper abdomen and thoracic surgery. What are the clinical indicators of failure for basic respiratory support? Increasing respiratory rate to more than 30 minutes, increasing oxygen requirement to maintain the saturation, partial pressure of oxygen less than 8, partial pressure of carbon dioxide more than 6.5 with respiratory acidosis of less than 7.35, dyspnea, exhaustion, drowsiness, confusion, or low GCS. What are the indications of tracheal intubation? Airway obstruction, airway protection, hypoxia or hypercapnia. Unconscious patient are those with impaired laryngeal reflexes to prevent soiling by the gastric contents of the blood, air via toilet, or to facilitate the mechanical ventilation, and the anesthesia. When muscle relaxation or mechanical ventilation is required, prolonged surgery, one lung ventilation, and prone positioning. What is the aim of mechanical ventilation in intensive care? What harm can it cause, and how is this minimized? The main aims are to maintain oxygen and remove carbon dioxide. Ventilation can cause harm by repeated opening and closing of the alveoli called atelect trauma, overdistension of the alveoli, volute trauma, high pressure within the alveoli, barotrauma, release of inflammatory mediators, biotrauma. These can be maintained by limiting the tidal volumes to 6 to 8 ml per kg ideal body weight and positive end expiratory pressure PEEP to increase the functional residual capacity. So limiting the airway plateau pressures to less than 30 meters of mercury. Oxygenation is mainly a function of the inspired oxygen concentration and the mean airway pressure, and is improved by increasing the FiO2, that's the inspired oxygen concentration, and increasing the mean airway pressure by increasing the PEEP, and by increasing the respiratory pressure, or by increasing the respiratory time. Inspiratory pressure and inspiratory time. And carbon dioxide elimination is mainly a function of the alveolar ventilation and is improved by increasing the respiratory rate, or increasing the alveolar ventilation by increasing the tidal volume, or reducing the dead space, or both. What is CPAP and how does it improve oxygenation? CPAP is the application of positive airway pressure throughout all phases of respiration, inspiration and expiration. This increases mean airway pressure. So delivered gas flow must exceed peak inspiratory flow. Gas is delivered to the patient via nasal mask or face mask or the hood. It requires tight seal so that the patient can only breathe in through the respiratory circuit. So continuous positive airway pressure has several positive effects on ventilation. So it increases the functional residual capacity by recruiting the areas of atelectasis and decreasing the shunt. And this reduces the work of breathing and improves the oxygenation and due to decreased chant. And number 2 is pulmonary lymphatic flow. It increases the pulmonary lymphatic flow that allows the lung to clear pulmonary edema. Number 3, it improves the mechanical function of the heart in cardiogenic pulmonary edema to prevent further fluid up. And indications of CPAP are hypoxemic respiratory failure, pulmonary edema, and sleep apnea. So all patients who have sleep apnea, they normally use CPAP at their home. Define a flail chest and describe how the principles of managing a patient with a flail chest. So disruption of the chest wall integrity, part of the bony thoracic cage that is detached and from the rest of the bony cage, and so does not contribute to the lung expansion. This flail segment may be paradoxically pulled in on inspiration by negative intrathoracic pressure. Requires at least 2 fractures rib per two ribs, 2 sides. Can occur secondary to thoracic trauma with multiple fractures involving the several ribs, and complications include the hypoventilation due to impairment of the chest wall mechanics and the pain, underlying pulmonary contusion or pneumothorax, and sputum retention or infection or poor nutrition, often due to the gastric stasis. Management aims to prevent the development of pneumonia by protecting the underlying lung, ensuring adequate oxygenation, ventilation, and clearance of the excretion. This should be therefore include the supplementary oxygen, analgesia in the form of opioids, intercostal blocks, paravertebral blocks, and thoracic epidural chest drain if required, if there is any hemothorax, and physiotherapy to aid secretions, clearance, and re-expand the interstitial lung. And patient might need continuous positive air pressure CPAP or tracheal intubation if unsatisfactory arterial blood gases despite preceding measurements. And last resort is the possible surgical fixation.